Nice. Apologize. All right, so let's get more people on. So 3, 4, good.
Yay!
All right, everybody. I know this is not exactly what you want to see when you turn your phone on, but here I am. Can you tell me if you're getting a good signal? All right, here they come. They're coming on more. Here they come. Boom, 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 boom. Better? Better? Good. All right, getting good comments. That's better.
Better. It's better. Yay!
Sorry. Things beyond our control. Can I just mention something? You know, all of this that we play around with, this stuff, is, oh, thank you, good connection. This is low tech, okay? Just think about the technology of what you're using. Your eyes, your ears, your body, your fingers. This is high-tech stuff, right? That's why, you know, I mean, we're talking about a solution to help fix problems with high-tech stuff, but we're having to broadcast it over low-tech. I mean, I know some people make the mistake of thinking that they're technophobic, and they think, you know, because they can't use a computer, they say, oh, I'm not smart enough, or I'm afraid of technology. No, you're not. You're just irritated by the inferiority of the technology. You know, it's the average computer and cell phone is high tech compared to the old rotary phone. It's high tech compared to 2 cans with a string, but it's not high tech compared to you. How you work, how we operate is so much infinitely higher tech than what we're using for this broadcast, for example, that your technophobia is probably just, you know, a lack of tolerance of the inferior technology that you're using, because you want it to anticipate your needs, work for you 100% of the time. You shouldn't have to type or have to do anything. So, you know, we're going to operate knowing that our technology is inferior to us, but we're still going to teach some great stuff regardless. Okay, I think almost everybody's in. All right, good. All right, we're going to get started. So,
can you introduce everyone?
Yes, can I introduce everyone? Let's see. Apps. Okay, here's the lovely Camille, massage therapist extraordinaire with 30 years experience or so. Yeah.
A little more than that.
A little more than that.
Even more than that.
Way to go.
Even more than that. Okay. We have our one of our favorites, not only patient but student. He takes everything he learns in the treatment room and he applies it to other people. And actually, he's found ways of even using it to help his dog, who was hit by a train, was it?
Yeah,
a train. Wow.
And his brother-in-law?
Mm-hmm. And his brother-in-law. So,
Nephew?
Guys, Kurt here. Thank you so much for joining us, Kurt. And you, I don't know.
Okay,
So I'm Dr. Justin Toss.
Hi, nice to meet you.
Nice to meet
and
you.
Everybody out there. I'm Deborah Dar. I'm a physical therapist, massage therapist. I teach Feldenkrais. And I actually got here through one of my patients who was just with knee pain, who's just started to come, and I thought, I want to see what all this is about, because we only got a teeny bit of trigger point stuff in school, and I'm just really happy to be re-seeing it. And I have problems with my feet, so I'm really happy to be here today.
So I'm Dr. Justin Tossing. I met Sharon years ago at a health fair where my partner, who was at the booth with me, was suffering from a migraine headache that I was unable to help her with, and she went off to just mingle because she literally couldn't stand at the booth. Her eyes were watering and whatnot, and came back looking like a new person about 10 minutes later, and that's how I met Sharon. So she had gotten Sharon to work on her and evaluate her, and within 10 minutes it was no more migraine, just gone, poof.
Gone.
Yeah. So, and I will ditto that comment that in school, in the field of trigger point therapy, is less than we got on obstetrics and gynecology. So, and I'm a chiropractor. So, I mean, we got almost nothing is what I mean to say. You know, the biggest thing I would say is that we were taught just to push on little tender spots in the muscle. We were not really taught the extensive, beautiful maps of where pain comes from. We were not taught that almost every pain that someone suffers from physically has a myofascial component and can benefit. Somehow all these red things all these red patterns on the wall, they are consistent, they're 100% accurate. This is a science that, unlike almost any other field of pain, has really been researched and is thoroughly documented and is hardly practiced accurately. And then I met this woman who actually practices it accurately and uses it in the and so that's how it came to be. Now, as we know, trigger point therapy is a field that operates on a 3-part diagnosis, which means you have to have pain in a pattern like the ones we see on the wall. Ooh, I'm getting hearts too. Look at this. I might should talk more. You have to see pain in a pattern like this on a wall. There has to be pain. Then part 2, lots of hearts. See, more comments there. You have to have a range of motion test that fails. That's all these guys on this wall. You see, it's actually as much about charts as it is about anything. No, just kidding. And then you have to have a super high tech diagnosis. I mean, higher tech than MRI. You cannot diagnose a trigger point therapy with an MRI.
No moving.
You can't diagnose a trigger point therapy with. You can't diagnose it with an electron microscope or any other of these so-called high-tech instruments. You need something far more intelligent than any of that, a technology that so far no one's been able to reproduce anything close to the intelligence of this technology. It's called palpation. It means that you take the intelligence of your own hand, the innate intelligence of your natural innate intelligence toward healing and medicine, and you'd use this instrument to find where the tissue is not doing what it's supposed to be doing. And it's an instrument that grows with you. The better you get at it, the more you use it, the smarter it becomes, or the more you're able to access its intelligence. And when you become someone who's been doing it for 30 years, like 2 of the ladies, possibly 3 of the people, and even Kirk and myself, we all become more intelligent and awake in all areas of life. And that's why we love body work, and that's why it's really good for all of you to do it. So that being said, you've got your 3 prongs of diagnosis, which is pain pattern, range of motion test, and palpation. And then you have your 3-prong approach, which is you warm up the area, you compress the tissue that's dysfunctional, and you put it through its full range of motion. In addition to that, there's this magic that no other field quite captures as well, which is perpetuating factors, things that cause pain to come back, cause the myofascial system to dysfunction over and over and over and over again. And the one we're talking about today is the number one, probably most important single perpetuating factor that starts to cause pain in your patient the second they walk off your table, the second they put their feet on the floor in the morning. And that is a congenital anomaly that is very common throughout the world, and that is that the second toe developed fully, but the first toe congenitally stopped during part of its development and came up short compared to the second toe. And I have it myself, and the way you easily see it is balancing on one leg.
It's good to do that.
Yeah, it's good to do that. Is that you bend your toe just like this, bend all your toes, and then you measure.
Right here.
And it'll be fun if you find someone who has it looking properly. You'll see a nice little line where this first toe should be out here, is where that knuckle should be. It shouldn't look like a triangle. When you've got a triangle like that, then the pressure that goes through that foot becomes like a knife blade. Yep. That becomes right along that line from heel
So it's like
to here.
it's a, sort of stand on this one here.
It's like if I was to stand on top of this pen, my
It's like
foot.
you're always rocking from side to side.
Yep.
Like that. You constantly. That's why, in many people, you get a bunion. Or you get a wear right there. Let me look at the other one here. So you get a really good callus right there.
Yep, there is
Okay.
not supposed to be weight going through the second toe. The pressure points on the foot are
Should
supposed
be
to
on
be
the first toe,
first toe for push off,
right?
and then equally between these
Those two?
3 and this point here,
And the heel,
those 3
yeah.
points equally when standing.
So that should be like more of a tripod,
Exactly.
like that. And
Mm-hmm.
but what's happening is it's like a knife blade down the center
Yeah.
instead.
And people will tend to either brace, which means they'll pull way out hard,
Like this.
and every muscle laterally rotating the leg from the, all this tibial, fascia, iliotibial band IT band, all the way down to the peroneal group, everything down here. There'll be
They even
trunk.
can bow out.
Yeah.
The muscles can be so strong pulling them out that they get bowed legs.
They can bow their knees out, and
Yeah.
and they love to roll their ankles. And then they have
That's a bracer
a bracer, and then they have the people
that fall in.
that fall in, and they get the knock knees. You just
Knees,
you know, you can practice as you're walking down the street, especially in Chicago, and you've got lots of people. Just walk behind somebody and watch their ankles sag in every time they're walking. They do exactly like that. They sag in because to get over that second toe, they've got to roll on top of the big toe. And so there's excess rolling and wearing on that ankle. So this is a big deal. This is huge. You could make your whole practice off this.
Okay, you could just be
Yeah.
a first metatarsal deficit corrector, and that's your whole thing.
But of course, if somebody ever goes to a podiatrist or you know, they get orthotics.
They never correct the first metatarsal
Yeah,
deficit.
yeah.
And then it doesn't correct the bunion, and then you get the bunion again.
Yeah.
Then you have to have it taken off again.
Yeah.
So it never corrects the bunion.
So you could
If you don't
spend
correct the reason why you got the bunion comes back.
you can spend $600 on a pair of orthotics.
And they won't have the
There's
first
not even the
metatarsal.
slightest evaluation for the first metatarsal deficit.
Nope.
So
Okay, so we're gonna take a look at. So see if everyone in our audience could look at their own feet.
yes, please
And then
start doing this.
You're going to take a look at each person's feet, and you're going to, let's bend a little bit right here so we get it right at the metatarsal head here, and put a little dot, and then I'll go along the dots. And if the second toe joint here, the metatarsal head is longer than the first one, you know that you probably have Morton's foot.
Yes.
Okay, so we found that Debbie has Morton's foot.
Oftentimes you see a deep groove in between the first and second toe.
And you have a webbed toe between the second and third.
Yeah.
Okay, so it's sort of like webbed here,
Can you guys see how
and it's
this
deep,
is a congenital
deep there.
anomaly?
Plus, you tend to get what's this called? Hammer toes.
Oh, yeah.
Because you're trying to balance all the time. Instead of it being a tripod, it's a knife edge, and because of that, you're trying to balance, and you get hammer toes. Okay, so. Yeah, all those things. Let's take a look at this foot here. It's got all the things that you have. It has bunion here. It has calluses. It has callus here on the toe. It has callus here, over here, over here. It has the metatarsal head longer on the second, and it's webbed between the second and third, and longer between the first and second. So it's got all those things. But then, what happened is that was Morton was way back in the 30s and 40s, but Dr. Rothbart began to, he listened to Dr. Tavell. He was one of the American Academy of Pain Management doctors and myopain doctors, and he was Dr. Tavell's student, and he said, well, he was a podiatrist, and he just thought this was sort of rubbish, but then he began to study it, and he found that they looked at a lot of skeletons of different tribes and stuff that were done like in 1800s, and they found that peoples that had been barefoot had their talus bone up and down, and all of us that have been in those Western societies and Eastern societies where we've been in cultures and cities and stuff, and wearing shoes, the talus bone was more horizontal, and it caused a different formation of the foot. And this has been going on, and it actually is progressing. A lot of the people that have, like, say, for instance, the formation you have in your feet, your children often get it sooner and worse than you do. So it's like a progressive thing getting worse as we're going forward in culture rather than better. So it's not progressing and getting improved for one reason or another. You know.
Okay.
So this is good for us all to correct it. So let's take a look at a couple more feet. So let's take a look at your feet. Okay. Okay. So let's see if we have Morton's foot here.
Dr. Kirk.
Okay. So we're going to take a look at the metatarsal head here. So we're going to feel right here, and we're going to go here. The metatarsal head's right there. So you can sort of feel it. You can feel the heads right there, and then you come here, then there. You can feel it right there and here. So then you can see, this one is more forward than these. So so this sort of indicates that he would have that knife edge.
Exactly.
So let's see. Do you have a little bit of calluses? Do you like to sand them off?
No.
Okay. So
Well, have you done
doesn't.
some correction by having the insoles ever?
Yeah,
or-
he has.
Yeah.
He's
So you've been wearing them. So
He's been wearing the insoles, so he doesn't.
the same thing
So he
happened to me
doesn't-
when I started wearing the insoles.
Yeah,
and I
he doesn't
stopped
have
developing
No,
calluses.
he doesn't have
There's a
hardly.
little one on this one, though.
Right, there's a little one right here, just a hair. This is hardly any callus. So he's doing
this-
pretty good.
so-
He's got it very webbed between the second and third, as you can see.
If he did not have the correction Sharon put in, how long ago did you put in a correction on this?
It was February or something.
So it's like quite a few months now. That's long enough. That length of time, you could make a big change.
So somebody,
yeah.
so somebody
You can make a really big change in that time, really big. Yeah.
Yeah.
So let's take a look at this one. Okay, you look at this one. You tell me now. You see what you think. Okay. So you evaluate this foot here.
Okay.
You take a look.
So, let's see. So if I go here, then the head is about here.
Yep.
Okay.
You make a little dot there, here at the top.
Okay. Head here is, can I be feeling the head? I think it's there.
Well, there's more ways to evaluate the besides
Yeah,
just
okay.
this evil way. This
Okay.
is one. This is the
Here.
beginning way.
And here, so plunk, plunk. So it doesn't look like it's as exaggerated, but maybe I
Uh-huh.
didn't have the right
It's
place
all right.
for the head.
It's okay.
And
So
there's
this
a
one-
web. There's
This is
web
web
here.
between here. Okay.
Right.
It's more thick. It's more right. It's deeper there.
Right. And there is. Can I?
Go ahead.
There's a little callus there,
You do that.
more
Yep.
than on the other. Okay. I don't really feel
Oh, a little bit of
That's
bone
blue.
growth maybe right there. Yeah.
there. Okay.
So pretty good. Pretty
sorry.
good.
I know.
It's a nice
I don't-
foot. It's a nice foot. Okay.
Okay.
It's a good foot. Okay. So
Okay.
so this foot's a little different than the other foot. Okay. So let's see. Let's take a look at a few more things. Let's take a look at the two of you now standing, and see what we notice standing. Well, one of you at a time. Yeah.
Okay. You want to go?
Yeah, come on up. Yeah. So we're going to take a look at you standing, and we're going to look at without his shoes on. And so here you see that his left shoulder is a little lower than his right, like that. So walk in place for a second, and then stop. Okay, so you see here his one shoulder is lower than the other, and maybe remember that thing that I had the other. Okay, there was like a stick or something.
Yeah.
Okay, so you can see that. So the left is about a little less than an inch lower than the other side. And let's look at the heights of his hips a little bit. So let's go ahead and look at the posterior superior iliac spine. And you can see that's a little lower on the left, okay? And a little higher on the right.
Why walk in place?
Okay, just in case he was presenting, in case he was trying to correct himself. And I was just like to see if he had, I just sort of see, just change, making him go back to the way he usually is. Okay, so here, so this is lower, so I'll write this all down in a second. Let's come over here and look at him from the side. So, yeah, you can turn sideways, that's fine. Okay,
You go
so-
where you need to be.
So here, so he's correcting himself a little bit, but he was standing a little bit forward, so he bends a hair at the waist, and his head's a little bit forward here. So a lot of times that's corrected by putting in the first metatarsal correction. Okay, so let's take a look and see if it corrects it. We'll take a look at a few things, but first we're gonna look at the ankles and feet, and then we'll look at the rest of you.
Can I show you what a normal foot looks like?
Go ahead, would you?
So here, someone asked if I could see a normal foot. So here's a comparison of what a normal foot would look like. Which one is the normal foot and which is the Morton's foot? Oh, also, guess what Morton's foot is called? It's called Greek foot. I told you it was an Anglo-Saxon congenital deformity. Which one is the Morton's foot?
Right.
Someone want to type the answer? Oh, okay. Well, for whatever reason, someone said right. That's good. And here's another example of it. See? That long second toe. Yeah, right. Good. Okay, so, and now here it's the left. Ha ha, I switched it on you, so now you can't tell. Here it's the right. Exactly. It's on the right-hand side, this one. And then here it's the left that has it. So this would be a much more comfortable foot to have. Now, I'm going to show you one more thing. Everybody needs to go to myopain.com. Come on, here. There you go. myopain.com. This is our website, okay? And you go to resources and you go to Muscle e-newsletter archive, okay? although some of you might use our newsletter service already. I think there's a few I have to get back to you because you wanted to. And you go down to the bottom, and there's this one here. It says, is this, it's the second to the bottom, common foot condition wearing your knees out. Click on that. Now here is a great article on Morton's foot, and it's simple, patient-friendly language. Okay, it talks about what we showed right here, the short first metatarsal, the deep groove in between the toes, the pressure. This is a pressure plate analysis of someone's foot with Morton's, and this is a pressure plate analysis of someone's foot without Morton's. They have a tripod versus a knife edge. And then this is what you see when they're walking on the street, ankles pronating or people yanking them outward and causing a lot of tension. That's called the bracers. So this explains everything. It shows you what it looks like, shows you the callus formation, where they're normally found, shows you shoe wear, and shows you a simple test to do it yourself. You just stand with your feet apart, shoulder width apart, and start to bend down while looking in the mirror. If you have Morton's foot, your knees will knock together because you have to get over the second toe to get onto the first toe. Your knees will start to come in. Not always for strong bracers, it may not be the case, but for most people. And that talks about the simple solution, which is the cheapest kind of insole you could ever imagine, you know, and some things that you can do to work on the muscles. So here,
Yeah, so sometimes when you change your feet, then you might want to work on your muscles because then they have to get used to the change that you just put in. So
Yeah.
for a few days or a few weeks, you might want to treat yourself.
Yeah.
And give yourself a little treatment to make sure you fix all the changes that occur.
exactly. So you'll want to have a copy of this printed out in your waiting room, and you'll want to call. The next thing you'll want to go to is you'll want to go to
How many of these have we created, Justin?
newsletters.
60?
Close. It's over 50.
Wow.
I know that much.
Yeah, so we've talked about fixing about 50 to 60 problems.
MortonsFoot.com.
That's a lot of problems.
It's a lot of problems.
That's
And-
most of the
Everything.
problems. That's
everything.
most of
That's
the
everything.
problems in the body.
Here's a picture of a toe that looks normal. They have some on here probably too. But so MortonsFoot.com, you call these people up, this number, and ask to become
A posture
a
pro.
posture pro and to be a professional in the field of Morton's foot and help people with their pain. And they'll set you up with a kits, and and they're just, this is not a gimmicky company. It's like awesome family run, same kind of integrity we have, and you'll love them. Bjorn and Milady, they run the company. They're husband and wife out in Seattle. They're gorgeous people, and it's not like a multi-level marketing or anything like that. Not that there's anything wrong with that, but I mean, this is just straightforward, good, good medicine, and you can make a little money off the products. But the main thing is you become well known for being able to fix problems no one else can fix. Okay.
Okay, so let's take a look
Yes.
at correcting.
Yeah.
All right.
Okay.
So we're going to sit with your back towards me. Okay, so you can get down low, Justin.
Yes. Let's
Okay, so let your ankles fall in a little bit. Yeah, like they were a second ago. Okay, so he tends to be, if you've been wearing the inserts, you tend to remember to be straight. And so he's getting used to being straight. So
Yeah, he's correcting
so
himself.
he's good now. But let's just take a look at feeling a few parts here. Let's look ahead. Roll your ankle out.
Okay, so what she's
And
doing
roll
is
your ankle in.
she's
Okay.
feeling the
And roll your ankle out.
she's feeling the medial and lateral malleoli,
Mhm.
and they should be level at normal standing
So
position.
so you're looking for the malleoli to be a little bit more like that. So when you do that, you're looking that his toe comes off the ground a little bit.
Yes. So if you get the medial and lateral malleoli to be level,
Mhm.
and then you look at his toe, it'll be lifted off the ground.
Now you see how he likes to turn this one out. So I'm going to make that even.
So
Like
make
that?
the malleoli level,
Now I'm going to push the malleoli over a little bit.
and you can see how there's a little bit of space. But he's already been correcting. We'll see it worse in someone else in just a second, probably.
Yeah, so for him, we're just going to put a little bit of correction in.
Okay.
And then we're going to take a look at, then we're going to take a look again at his shoulders and his back and look at his hips. So we're going to go take a look here. And you see, oh yeah, it's a little higher here. So that usually it's sort of like, it helps in a way that it even though if you're correcting both feet, it evens, if you're uneven, it evens out your hips and your shoulders in many cases.
Yes, and if you don't feel 100% confident at doing the full posture analysis that Sharon's doing, just the part on the foot, even that is good.
Yeah.
Just
So here,
being able to keep
this
them.
is even now.
Yeah.
So I only put like about 5 millimeters in, and it's correcting everything. You know, so that's good. So let's also have you step backwards, okay? And let's look at you. Let's go ahead and watch his knees. Let's see. Go ahead and bend your knees.
Okay, yeah. So here's
Come on in.
here's the test that you can have people do. It's good when people can see themselves. So just come down a little bit more, and you see how they want to come in. See how they're starting to squeeze inward. See?
Wiggle a little bit.
Yeah.
So then when you put in so then you know that you need a little bit of a correction. So then we're going to put a little bit of a correction in, and just put it in the big toe. Go ahead and bend your knees.
See, they no longer bend in. Let's do it without again so you can see a difference. They don't wiggle as much either. See what starts to happen? And he loses some range of motion.
And it looks as
Yeah.
though the right foot starts to turn out.
Yeah, it starts to turn out. Yeah, he's
Yeah.
trying to get the foot out. So
Or both.
what the lift here is bringing the floor up to the toe.
Yeah.
So is this your insert here?
Yeah.
And do you have 2 of them?
Yeah, it's
Yeah.
another shoe.
Okay, so
So
this is his insert that he wears, and he has 6 millimeters and he's been wearing, and then we'll
Got
put.
this one taped on it. And this is the glue.
Okay, good. Okay. So there you go. So I like to put the shoe inserts on the floor or put them in his shoes. I like to see how it does.
Can you show us the knees again? Have the knees pants up a little bit. Sorry. Yeah. Okay.
And also the other thing I notice is just stand straight now.
And I would say that he's not on his shoe exactly right. Can you
Oh,
get?
okay.
Because you could see his knees were still doing a little funkiness, but you weren't quite on the lift part. There. Okay. Give it a shot again.
And it's better when you have the shoe on also. So we're gonna check a couple more things, and once you put the shoe on, and then we'll check you
Yeah.
with the shoe.
Yeah.
Okay.
So also the shoe itself
Yeah.
holds the ankle in position as well. Yeah. Okay, so let's take a look at Debbie here.
And can we talk about the correction for just a quick second?
Yeah.
Sharon said that it's bringing the floor up to meet the toe, so you don't have to get over that second toe in order to put your toe off. When you are in toe off, the majority of your entire body's weight is being pushed off by that big toe. And that big toe is, think about sprinting. Think about starting from the sprinting position. You're crouched, you're ready to go. Who wants to get in a sprinting position? Michelle's sprinting? Yeah. She's about ready to go. Think about, you see that right there? Right there, this toe right there, that is about to take, well, if maybe twice her body weight when she goes to launch. So that's going to take about 2 times her body weight, just that complex right there. So that's not the part of your body where you want to have an imbalance, but we do. So by bringing the floor up to her toe, then she does not have to do anything weird to get the right amount of pressure and balance onto that first toe.
Okay, so let me go ahead and take a look at you here and see what you have.
Okay, but we're gonna talk about that correction. Is not to completely take away the deficit. Obviously, that's congenital. It's to give enough of a lift to train the body to be different in its postural behavior. So when we find the perfect amount of lift using those wedges, that's what these wedges are. Can I show they have millimeter markings on them. See, they have 10, 15, 5, 10, 15, 20. We use 1/3 of that generally. Put the amount under that corrects the postural deformity, but in general, it's about 1/3 of that is what we use for the correction, because we want the body to do its natural correction. We don't want to take all of the lift out. So that's why this is training.
Okay, let's go ahead and watch you bend your knees.
Okay, see the knees again? So is this without anything?
Yeah, so
Okay.
they come in a bit, come on up,
Well, can you go lower?
And bend
Oh,
in.
see? Yeah, you see how they want to come in?
and they
Go-
sort of wobble.
Especially I
a
can
little
feel
bit.
the right one.
And you can feel it want to come in. Yeah, go
Yeah,
even
see
lower
right
if you
here.
can.
Yeah, that's it. Yeah,
Yeah.
so that's
Yeah, see, they'll almost want to touch and start to wobble and come
Yeah.
in. Yep.
Okay, then
And you feel pressure in your knees, right?
Oh, yeah.
Yeah, it really
Okay.
wears those knees out.
now if you take a
Yes.
look, Justin, up here, her left shoulder is lower,
Okay.
and her right shoulder is higher. and left hip is lower and right hip's higher.
Okay.
So if you take a look here, you'll see, if you go right there, you'll see
Yep.
it's
left
just like
shoulder
that.
lower, Yep.
Just like that, and also the same thing here.
Okay.
Wait,
So-
so this is, left is lower?
Yep.
It
Yeah.
feels like it's higher to me.
But it's lower.
Yeah, okay, but-
Who wants to look? Yeah, it's-
I feel like I'm like this.
Oh yeah, the left is
Yes, you
lower,
Okay.
and the
Yeah,
right
that
is
is right.
higher. Yeah.
You're absolutely right. You just don't know which is left and right.
Okay. That's true.
It's arbitrary.
That's absolutely
It's
true.
arbitrary.
Okay.
Point to your left side.
Okay,
No.
now we're gonna look
Okay.
at the ankle,
Okay.
and I'd like to make the ankle even. So like I go like this and make it even. Also, I like to look for the subtalar joint. So here, let's have you roll your ankle in, roll your ankle out, and what you want it to do is feel kind of flat right here at the subtalar joint. Roll it in, and roll it out. Okay, right where it gets flat, right there, a little bit more there. That's right where it's even.
That's even, and you can see how her toe
And
is
now
off
toes
the ground.
off the ground. Okay, so
See?
so then you want to take up the slack there. Okay,
Yep.
that's 15 millimeters.
So she has it very
Okay.
significant, and you can see the
Yeah.
amount of foot deformity that's
Now a lot of
developed because
times when you
this.
do that, now you can
Yeah.
see that the arch starts to go up.
Yep,
okay.
and it helps the
So
arch.
the arch is starting to come up. So that's good. Let's take a look at this side. So let's roll it in just to feel it. Let's roll it out.
You could just see that ankle joint and how
And roll it
unhappy it
in,
is. It's just
and roll it out.
happy.
Okay, I can feel
Right?
that
Isn't it
subtalar
unhappy?
joint
Yeah.
right here. And let's
So
see if we can
unhappy.
make it flatter. Let's go lateral again. Okay, about right there. And we take it about to there. And then we're going to go ahead and put the lift right there. So that's a little bit less than 15 on that side.
Yeah, maybe you
Okay.
get it deeper under
Okay.
because it toes out to
Okay,
the side.
so there we go. Let's take a look now and see if you bend your knees. Okay, so less of a tendency for you to bring them in.
Yeah, go ahead and go
So
down
that's
lower
the-
if you want.
Mhm. So it's still coming in.
Still coming in a
So
little
we
bit.
might-
Oh, there it goes. See,
Mhm.
not so bad. So
Mhm.
now remember,
Mhm.
it's
We might want
it's
to go just a hair higher.
yep, and its pattern of behavior
Yeah.
is to go in.
That's true.
So
That's true.
so it's going to correct itself. There you go. You
But
see?
it feels so good.
Doesn't
Yeah.
it feel different now?
Oh,
Okay,
Oh,
so
yeah, right,
so
the
that-
knees
so a
feel
little
better,
higher.
the hips feel
we
better.
want to
My
look at a
ankles
lot
feel-
of things. We want to look at the
Yeah.
ankles. We want to look at everything. Now look at this. Oh, it's like stable. Look at it feels different. Okay. Every muscle will be stronger. Everything in the whole body will be stronger. It's stable. You can feel it.
well, yeah.
So come and look, Justin, at the height of the shoulders. She's got shoulder blades we can actually see here, sticking. You can see it
Yeah,
right there,
yeah.
and there it is. Look it.
Yeah.
So oddly enough, we put it in both feet, and it made her even. Okay.
You're
And-
welcome. Someone said this is awesome. Yeah. And
And
this
then-
is so important, guys. I mean, you've got people walking around
Okay, and here,
as if they've got ice skates
even.
under their feet.
Yeah. So it's again even. So here, now the other thing we want to look at is how is their shoulders and neck, their head position.
Mhm.
So let's have you. Yeah, good, Justin. Thanks. Okay, step off of them, and
Step back off of it.
so it's and then let's take a look at you. Okay, so that's not too bad. Looks pretty good.
Yeah, looks
Her
pretty
ears
good.
pretty good. But let's go ahead and step onto them again. So just the big toe, not the whole arch. Just the big toe.
I'm sorry, here.
Thank you for the advocacy. Someone said I wear these. They're awesome. Yep.
Okay.
Okay.
Okay. So then now what does it look like?
Wow. You see how her
Looks
her-
more relaxed.
Yeah, she's
yeah.
more relaxed. Her
Yeah,
head is
and
more
then-
over the
and
shoulders.
It's sort of like
She's
like you
back
want to go
more.
back a little more.
I
Because,
feel like I can feel the bottoms of my heels now.
yeah,
Yeah.
so it's like your
Right.
feet are more on the ground. Yeah.
Yeah.
And you're back on your heels a little
She's
bit.
grounded.
And so
Yes. Yes, I am. Yes, I
okay,
am.
so
Yes, I am.
so it's a simple change, but
Okay.
even though you have a big correction, there a lot of times we like to start with a small correction, okay, and then maybe
It doesn't go
eventually
berserk, yeah.
go to a higher correction.
Yeah.
So why don't we just try your shoes on with the correction in
Okay.
and see how it is. We just put 3 millimeters in her shoes, and we'll just see if that also corrects it. So,
What device did you use to put
I
in your
just
shoes?
put the what's called the Soulmate in. The 2 bags of them
Soulmate.
sitting
Here's-
right there.
Here's Soulmates.
Yeah, Soulmates.
They just
You
stick
can glue
in.
them onto your feet, or you could do a yoga in them, or run around barefoot,
Yeah.
or you could put them into your shoe.
Yep.
On like this. They're not permanent. That's why you get a whole bag like that, and then you just put them on every day. You put a new one on your feet if you're barefoot all the time.
Yeah, well, that's Sharon. Sharon is. I have found that mine lasts for months, but you could do a new one every day. But you could also have them. I mean, mine are in my shoes, and let's see.
How long have they been in there?
They've been in there. Oh gosh, look at how old the shoe is. The shoe is relatively old.
Well, it's not that.
So, I used to have such bad wear, and you can actually see that the wear is so much better than it used
Justin,
to be. Yes.
Even with just the 3 millimeter, it's still more stable. She's still leaning a hair to the left, but very good. It's hard. It's hardly, like just hardly, you know. So if you took a look at it with just the 3, it's almost even. Okay, and then so it's still good, and it's good there. Looks good there, and let's look at it here. Okay, so it's still. So that's a lot of times why what we like to look is how much the deficit is, so we can see, wow, it is this, but maybe even just 3 millimeters. Let's look at what it does to you.
Okay.
And then, but it may not correct everything in the knees and feet enough.
Okay.
So we may want to go more later on.
The other, because these are the other shoes that I wear more often during the day. Should I put something like this in those?
Yes. Yeah. We should put the shoe. So we should put
Okay.
one of these shoe inserts in like this.
Okay.
And we usually start with a 3.
Okay.
And then we go up to a 6 or and sometimes a 9. You know, but maybe we want to reevaluate. So a lot of times we want to keep looking at you, look at your knees, look at your feet, how good you're doing.
Okay.
And she had surgeries on her feet.
Right.
Well, only one actually.
Oh, one surgery on her foot.
One surgery that went bad.
One surgery that's not good. So could we look at the surgery on your foot
Absolutely.
one time? So
It's what they said. It's called an ape toe. Is what he created because he moved the metatarsal bone too far. It was an overcorrection.
So
I've even seen
let's
it.
look at the 2 feet again.
Yeah. Okay.
So, Justin, if we could just look at her 2 feet. Okay, you can sit on my piano bench. Okay. Okay, so she had this bunion taken off, right?
Yeah.
And because of that, she created what they call an ape toe.
Ape toe.
Okay.
This goes way out.
And tell what they did.
He broke the bone and moved it, but he shifted it too far over.
Yeah.
I've seen the X-ray,
Yeah.
and the bone is over here.
Yeah.
And another doctor said the only way to correct it is to break the bone and shift it where it's
Someone
supposed
did that to my hip. I definitely sympathize with you. So.
Yeah. And it's on the same leg that I've had 3 corrective surgeries from a motorcycle accident, and my leg is almost always hurting.
Well,
I dance, I move, I exercise
She does
all
a
the
lot
time,
with it anyway.
but I have to work.
Let's consider that maybe this correction will eliminate. So if you look at her bunion, okay, you can see that she's got a pretty good bunion here, right?
Yep.
It doesn't hurt.
Oh,
it doesn't hurt at all, except when you pushed it out. But it does not hurt.
Well, I had a bunion worse than this, and one day it didn't hurt, but I said, why don't I see if I can get rid of it? Like, what will it take to get rid of it? You know, and I wasn't sure I could get rid of it, but I thought, well, they said you could, so why don't I try? So I treated all the muscles that would hold the toe in this position. So here, I treated the adductor of the great toe over here. They come this way. I treated all the interossei. I treated the anterior and posterior tibialis. You know, every day. Okay, every day, 6 months, totally gone. But worse than yours. This toe was way over here.
Wow.
Okay, and so mine was a bigger bunion. I'm going to show you my toes now. So in other words, it was all like this, like I was in a high-heeled shoe because I was doing waitressing in high heels, you know. Double shifts.
All right, well, show us your foot then. Show us your foot. Show us your foot.
Okay.
Show us your foot, then we're going to need to take a few-minute break.
So are you going to teach me what to do to my toes?
I will.
Because I want what you have.
Okay, so here, look it. I got rid of it.
Oh my gosh.
So it took 6 months, and now I trained all the toes to act normal. See, and they've been like this normal for 30 years.
But you wear your lifts on every shoe.
Yeah, I do.
Yeah.
So this is. So I'll show you what I have here. This is the insert that came with the shoe. You might put that on top if you want to, or not. It's not necessary. And then here's a really old pair of these 9 millimeters. So I've got 9 millimeter, and I have also on the other one. So this one also I corrected. So I corrected both of them, and they're both straight now. And then this one, I put a little heel lift also. So I've got the shoe insert and a little heel lift. So for me, that's the way I do it for me.
Wow.
So
All right, we need to take a small break. But
oh
this,
yeah, we do.
But let's summarize this. The evaluation. We're going to go through it step by step when we come back. But this is the evaluation. The evaluation is you look at the foot. You bend the toes forward, find the knuckles. See if you have a second metatarsal head that goes out, sticks out beyond the first. Then you look for signs of wear, like calluses and bunion formation here, of callus underneath the second metatarsal head where there's not supposed to be any pressure ever. And you can even look at shoe wear if you want, okay? Then you have them stand up and look at their ankle posture while they're standing. And usually you do this from the behind, but you look, yeah, thank you. You look and you see if their ankles are bracing outward or flopping inward, okay? And then you go and you palpate to see how they feel and where they are in neutral. At the spot where they are balanced, side to side in neutral, you feel and you find that there's gap underneath the first metatarsal. You slide a wedge underneath it until you see that they're neutral again. And that you record, you say that's 10 millimeters, okay? And that gives you an indication that you'll want to use at least a third of that. You'll at least want the 3.5 millimeters. We call it 3, but I think it's about 3.5 is what they say. But you'll want the 3.5 millimeter correction. And then you'll have them now do the knee bend without it and see how they go in like that. Yes, thank you for accentuating. Yes, right? Yes, and then you stick the wedges underneath, and then you see how that went, there you go, and you see how the knees do not go in anymore, and you see how the patient goes, wow, my knees and my hips feel more relaxed, my ankle just feels better. If you have a mirror, you can show them how their posture looks. If you want to go into the advanced stuff that Sharon always does, you'll look, at the leveling of the shoulders and the leveling of the pelvis, and you look from the side at the up and down axis right there. And then you'll do the exact same thing with the shoe inserts. That's when you introduce the product. Then you introduce the product like this. You say, this is a very inexpensive thing that most orthopedic professionals are missing. And you don't need to spend $600 on a pair of orthotics because this is a very simple rubber thing. And you use you actually use this just as you did the wedges. You repeat the exact same things so the patient can feel the exact same benefits. You do the bending, you do the posture, you show them, and you say, can you imagine how much less pain you're going to have in your life if you just have those on? And in your case, it's so important, I would not even go barefoot. I would literally find a way to get some house shoes or sandals or something so that you never have that wear caused by your ankles turning in like that, okay?
Great.
So that's it. That's in a nutshell, that's how you do the evaluation. You can see that it can be done in 5-10 minutes. And you could go to a school and offer to provide parents with proper foot health, and you don't have to sell them something. In a proper foot health class, you could go to school, show the exact evaluation where you do the knees like that, show them how to bend their toes and look at that. Bring this little handout like we talked about, the newsletter, print one of those guys out that I showed you online on our website. Okay, and then give every one of the students one of those to take home with a little, this is how I measure it, and then show them how to do it for free, which means, how they could possibly glue a pad or something underneath their own shoe, cut out some, stuff from Shoals, or things, and put it on there for free, but also offer the reference of mortonsfoot.com and your office as an ability
so this
to
is,
help.
You could do something like this.
You could have an at-home solution.
Yeah, so you could take a shoe insert, you could put glue something on it and see if you can't correct that.
Yeah, because that way, schools will be very happy. If it looks like you're selling something, then they get a little worried. But if you come in, you offer them a free solution, and just think about all the girls whose scoliosis are not going to be as bad, whose feet are going to be beautiful.
All the kids that don't have sports injuries, knee injuries, ankle injuries,
heel fractures, those really nasty plantar fasciitis. Chronic ankle roll, sprains and things. So all that stuff is really wonderful. You could probably get a bunch of patients in your community just by performing this service, because it's a niche. Okay, it's a niche backed by so much great science and so easy to prove the benefits of that. There's no reason you shouldn't take advantage of it. Okay, all right. Sorry, we're keeping you over. All right, we're going to come back at. Oh, I can't do the math.
10 minutes.
10 minutes. What is that? That's going to be
Almost there.
8 o'clock, 2 minutes to 8.
So 7:58. Thank you. All right, 7:58, folks. Thank you.
Yeah, we have all the shoes. Can you pull out the size for her? She's size 10.
I'm size 10 or 11. It depends on
10 women's. Give me the prokinetics. Yeah, this is all. Give me the prokinetics. Okay, so this is prokinetics here. So that's I'm sorry.
Do you want in the second part? Do you want to show?
I'm gonna give this to.
Yeah, great, perfect. You can explain it,
Yeah.
and then maybe you could talk about treating the SCI, and maybe you could talk about the muscles you can treat, and what protocol you might give.
Yeah.
Would you give them a protocol to go home
Well,
with?
the protocols for people with pain, that's the pain algorithm. The protocol, really, the protocol for dysfunction is different,
Oh, okay.
I didn't create the one for dysfunction.
Well,
But this
what's
is,
the one on the front? Which one would you
yeah,
try to
yeah,
give them?
okay,
Depends
I
on
was
the
thinking,
interesting.
yeah. Did you print that, when I gave you to print for patients, I said, would you print this? It had the rigidus, had hallucis rigidus. Yeah, we could do this one, yeah, we could do protocol 42, let's see what we got at 42. Yeah, this is good, so I do 42, and I do 40. So we do 40.
Oh, yeah.
Tibial anterior,
that
since
refers to the range of motion.
no, this is the range of motion, but I don't have a range of motion test for all the little teeny. Let me see.
RCI.
That's better, yeah. Yeah, the 37 maybe a little better, yeah. Yeah, 37.
Because when I put the shoe inserts in, it's good for them to.
Oh, yeah.
See,
Yeah.
I'll say my element complaint about shoe inserts.
Okay. Remind me. You have a complaint?
I have a complaint about any type of medicine that does not increase the patient's. Like if you're not waking the patient up to become more self-reliant and more intelligent and more in touch with their. Everyone has a sense of medicine, a sense of well-being. We're not getting in touch with that sense of well-being. I feel like we're not doing our job as a practitioner. So, in addition to this is just a fixed solution, I would also, Sharon always does, but I would recommend that they also get a feeling for those muscles. Play with your feet. Please play with your feet.
Okay, so you can give me protocol 37 and you can give me protocol 42.
Okay, 37 and 42. I'm going to print them from here.
Okay, so so I cut off your body into 60 areas, and then I put all the pain.
Say again?
Right, it's not the dysfunction.
You want print from it?
So I can make a whole new system just for dysfunction. Okay, but this hits the dysfunction, but doesn't hit the pain. I try to put the together by putting the range of motion with the
36.
It's 42, but it's to eliminate pain.
It's supposed to be
The
37.
person doesn't have pain. It's not exactly the same. It's not the other.
It is 37. Oh, it's got 36 and 37.
So, but I probably will do that.
And actually, one thing that I noticed when I was trying to
Okay, so 40. You got 44.
Is it
This is
print
44.
out?
Yeah, here's 44.
Did I say print?
Like 45.
No, it's 45. It's 40 is the other.
Oh, okay, 44.
What's that?
It's printing, right?
No, what is it? What is it? One of them. Maybe it's something that's trying to
Did you say 42?
Yeah, 37. Yeah, 42 the great toe.
Yes, great. Okay, perfect.
Well, either 40 or 42. Either one. So this is so for
Forty.
hammer toe that treat these muscles, okay? So this is for people with bunions. This is the muscle that's for your hip.
So you treated those yourself?
Yeah, I decided to do it every day for 6 months. And then I just thought, I just want to see what it took to get rid of it. I thought, well, why don't I just see? And then just see it. So I could write the Metatarsal Deficit. And then I did this. And then I've got many people to get rid of their bunions. Yeah, so just treating these muscles right. So the abductor helicis, the flexor helicis brevis, flexor helicis longus, neurossia, the foot, and the great toe joints. This has been really good. We also, might want to treat for the hammer toes too. So we treat all the extensors, the flexors, especially especially these extensors and the neurossia. Because what happens is the neurossia moderate the long toe muscles. So the neurossia are smoothing everything together like this, aren't working anymore. Then the long muscles overtake, and then they work too hard, and they pull up the toe. Yeah, that's what I did for 6 months. That's it. You did it. You just did it. Yeah. And I probably wouldn't take very long to get rid of all the pain. So the thing is what I'm working on is pain-free, but pain-free and full of function. Right. Not just pain-free. Right. Okay, so like pain-free, if you're like this, but I can't really, it's not pain-free. It's pain-free and full function. Right. So I'm not just looking at. So I hold out for you that we can change all the joints. We can change everything, make everything full function. It's possible.
Okay.
It could happen. It may not happen, but it could. It could happen. And let's see if you'll do it. Let's see if we could do it. Okay. Let's try it. Let's see if we can do it.
I still have plantar fascia pain in the left.
So could
I've
you
been
have the
wearing these since January.
do you have the plantar fascia protocol 38? But you've been treating. Can she have 38?
I haven't been treating it, but I've been wearing these inserts.
Yeah, but that's good.
You have to treat
No,
it.
that's good. That's really good. But it's doing both. It's not just.
Because this, see on this foot, this toe I think is longer
Yes, it is.
than on the right one. So this is
Yes,
the
it
side
is.
that has the plantar fascia. I have very high arches
Yes.
and
Nice.
insteps. I inherited that from my mother. Thank
Yes.
you very much. So is that part of the plantar fascia to the high arches? Is that possible?
High arches could be good. It's not a problem. So what we do.
Oh,
is-
that's not going to cause the
No, it
plantar
doesn't.
fascia?
No. But it's well, it could be. I mean, good to look at. Good to look at because maybe the high arch is caused by muscles being too tight.
Yeah.
Muscles that attach onto the arch
Right.
might be too tight. So we should maybe look at that. Yeah. But sometimes to relax the arch, what we do is not to hold the arch up. But if you have a high arch, then we put this in to give the place for the arch to rest on. So this is for plantar fascia.
Because I have the orthotics that give me more arch support and that feels better.
Yeah, so
But it's not
that's the only
totally
reason that we only do that for people with high arches, not for people with flat feet. We only put the arches in for people because so that they have somewhere for the arch to rest. Yeah, so that's why she's doing. So that's we would recommend that.
Orthotics and the.
Then that's what we would do. That's what we would do. Or you could try what we have. You might want to try something. So this is for plantar fascia. This is the plantar fascia.
Yeah, well, she's my full copy.
Okay.
She would definitely make more copies.
Yeah, I've been working on this for a while. I took the pictures and then over time, let me draw So you're wearing, today we have 6 in.
Yeah.
How have you been doing with the 6?
I think even better. It's hard to tell. It's even better.
What did you start with?
Three, I think it's 3 or 3.5.
Right. Because it was slight. It's slight.
Yeah.
But we were experimenting. We were trying the 6. We wanted to see if we liked it.
Yeah. I'm not against it by any means. And I think
So we
it's
tried it.
helpful.
Yeah. Because it seems to be helping. Good.
Might take a little while to kind of
Yeah.
for
So
sure.
other ways we might know.
But I've been standing all day.
Can I have you stand for a second? Other ways we might know is oh, that's he's not causing his peroneals to be really tight. Yeah. So that's a lot of times I'm looking for that. Yeah, good. That's good.
It's good.
Good legs. Good legs. Okay, good. We'll check on that.
I did notice that, if anything, I got a little bit more low back pain on the right side when I have it, but
So you've noticed a little bit more, you said?
it hasn't been very much lately. You know, since I was treated last week,
Good.
a
So,
couple times.
oh, good. So you did pretty good.
Yeah,
Well, that is good.
not like
That is not good.
it's not as often or as.
So what we tried to do with the correcting his underlying perpetuating factors, what do you think of resting more with things on your elbows?
I haven't done that.
Oh, okay, Harvey, we'll try that. So it's just because he tends to hold his arms out like this, it creates a lot of tension up here, you know. So I was suggesting, so I was mid and maybe lower. So I was suggesting that he take more time, put pillows under his arms and rest to give himself a really good rest. Like that, but a higher one on that side. And then it's like he'd be really rested, you know, part of the time, like when he gets home. Because he can't do it when he's working, you know. So he could do it some of the time, you know, where he's resting and relaxing. Oh, you can rest too.
Yeah, I was resting like this.
Good.
Oh, it's
Yeah, time to start. Time to start. Could help us. Okay, so let's look at your feet, and then we'll go on. We'll do some more stuff. Okay, let's look at you next. Hi, hello.
Hi.
Okay, we've got Camille here. We're gonna take a look at Camille, and look what she's done.
I dyed my feet.
She,
No, I
So-
wear toe socks.
so especially if you're trying to get rid of bunions and you're trying to correct your feet and wear your shoe inserts and everything, it's nice to wear toe socks because it encourages you to not have your toes too close together. It might be too much so maybe just a couple hours of toe socks sometimes, and then more and more as time goes on. But it
Okay,
can be
I'll take
it's
them
a
off
really
now.
good correction. Well, we could even see with your
Oh, right, but you want to see my
I
calluses
do. Let's see.
too.
Let's see. Let's see everything. Okay, let's take a look at you. And let's see if I have my pen.
I'll move over here. So she
Okay.
can- And do you want my inserts?
Yeah, we'll look at everything. Yeah.
Yeah, let's get those guys.
There. Okay, so let's take a look at your. Let's have you sit down for a second. Is that okay? That seat? It's a little high.
It's high, but that's okay.
Okay. Okay. Can I have your foot? Give me your foot. Okay. So we're gonna see does how if she has first metatarsal deficit or Morton's foot. So we're gonna take a look at the first metatarsal head, second metatarsal head, third, fourth, fifth. Okay. So you can see that this one is a little bit more longer. This toe's a little longer here, right here. So you can see that also the metatarsal heads are longer there too. So you know that this part here is most likely off the ground if you have this foot formation, and if you have the web between here and here, which she has. If this is deeper, which she has. Also, we're going to look for some calluses, which we have here, and a slight callus there. And we'll look. Does she have bunions? And I'd say no. And we're looking. Oh, tickling her. Okay. And then we're looking for. Does she have a callus right here? And she has a slight callus right there. She would agree. Okay. So let's take a look at her other foot. Okay, on this foot, we see that we have a callus right here and one here. So here, and then we want to look, do we have one here? And we have a little one there. And okay, so let's look at the, we have a, it's kind of a web between this toe right here, so it's a little webbed right there. And it's deeper right here. So then we call this a shorter first toe or a longer second toe. However you want to do it, or a Greek foot, or Morton's foot, or Rothbard's foot. So we got a lot of names for it there. Or hyperpronation. So we got all those, okay? Also notice how her big toe is curling this way. See how it's curling that way? I would hold out that we could uncurl it and get it to be straight. But I mean, it's not critical. But why not make it straight?
Let's make it straight.
Okay, so let's go take a look at her standing, and let's go walk around a little bit, and then turn around, and turn towards me, with your back towards me, and walk in place. Okay, so if you take a look at her feet, she likes to. While she was talking to us, she turns her. Well, she's fixed,
Now I'm thinking
she's
about
just
it.
fixed it now, but
Yes.
she turn them out. This is the way you were almost all the whole time. Yeah, she always turns her feet out. The whole time I'm talking to her, she turns them out all the time, every time. So now we're going to correct that. We're turning them in. So, but put them the way you usually do. Okay. Okay. So put them with the mount. Okay. And then we're going to turn them, change it. Okay. So here, look at here. You can see that this shoulder is lower than that one. So you can see that. So this is just about like that. Okay. So about this height, like that. So the right shoulder is much lower. Let's take a look at the hips here. So what's bad about having the shoulders different heights is that it creates different, it causes you to be tighter on one side, and you could be compressing the nerves on that side and causing heightened tone and muscle dysfunction. So here also you can see that this shoulder, so this shoulder is lower, this hip is higher, and this shoulder is lower. So if you put your finger on her posterior superior iliac spine, you see that it's like this. So her hip is this way, and her shoulder is that way. So this is like so like if you put a lift in here, it would make, in the heel lift, it would accentuate the height here and make it worse. And if you put the heel lift here, it wouldn't necessarily correct. So what we're going to do is correct the first metatarsal deficit. So let's take a look at her ankles and see what we find. And we need to have the blue wedgies.
They're right here.
Thank you.
And again, I wanted to just emphasize that if you feel comfortable doing one portion of this, then you can expand to do,
So turn around.
it all later. That's
Right.
okay too.
Okay, so I'm going to just look at you. Okay, now go ahead and walk in place. Let me see you walk in place and look around the room. Look at the ceiling. Okay, and stop. Okay, just stay there. Okay, now bend your knees.
Do you want to roll these?
Okay, let's see your knees better. Okay, bend your knees and come on up.
You see how they go in?
And bend your knees and then come on up.
And she has trouble bending as far.
It's like hard for her to bend any further than that.
It would be hard for you to bend further.
Yeah.
It really causes you to fail the heel down test.
Yeah.
Sharon, you want to show her the heel down test? We don't have to right now, but
Yeah.
you should be able to get your butt to the floor without
So
your
let's
heel
go ahead.
lifting
Let's
off.
go ahead and turn with your back towards me. So just right there, if you can keep your heels down, and if you can see how far down your butt comes to the floor.
And I'll hold. Sharon, you want to hold the camera? And
Okay, so
I'll hold her hands
okay.
and see if I get.
Yeah, but that's not how you do it.
Is that how you do it?
No.
I failed that test.
That's good. But at least you could do that. But you did that very well with him. But that's
Yeah, it's not
the
exactly.
way that you did it there was
Yeah.
perfect. Yeah.
Yeah.
Okay, so if you take a look really close and see her ankles and stuff.
Okay, let's take a look at the ankles,
Look
guys.
really good. Okay, so you can see they're like falling in. So if you can see, this is in, and this is falling in here.
Can
So,
I get in there? and see
oh yeah,
this
you
one?
do it. Sorry.
Yeah. See how the ankles are falling in? You know what you can do oftentimes is, give me a pen, please. Where's that marker we had?
Right here.
Yeah. Sharon, would you draw the line of the Achilles
Okay, I will.
tendon?
Okay, so
You can
here,
see-
so you can see the Achilles tendon is going this way, like that. Like that. So it's coming this way, like
and,
that.
And it can be worse in some people than this, for sure.
Yeah.
But you can see that the Achilles tendon as well. You see how it's bowing.
Going
Yeah. In fact, I
And-
would have. Yeah.
in like this.
Yeah. Yeah, I would have even drawn it in a little more. It's more
Okay.
like in there, but yeah.
Oh, you would go even a little more
Yeah,
there.
it's a little more.
Yeah,
So it's so this bowing thing
Okay. So this,
is another way of looking at the ankles. but
okay,
you can
now
also see
I'm
the
gonna put your
malleoli.
feet straight. Put your toe straight here, okay? And I'm gonna put this one straight, okay? Next, I'm gonna move the ankle this way. Okay, so can I roll your foot out? So can I roll your foot? So roll your foot out. Now, so I'm gonna roll it out and make the ankle straight.
Yeah.
Okay, when we make the ankle straight, then I take up the slack here. Okay, so then I'm gonna go here. So I'm gonna roll it there, make it straight,
Yeah.
and then I'm gonna take up the slack. Okay, so here we go. So now go ahead and bend your knees. Okay, and come on up and bend your knees.
Come around to the front here.
And come on up. So you still have a little trouble with the bending, yeah?
Yes.
Yeah, that's still.
Mm-hmm. Yeah. Yeah. So take a little bit out of it. Okay, let's take a look at the heights of her shoulders. Justin, let's go over
Okay.
here. So this would be taking a look here. Now let's look. Now the shoulders look a little more even.
Yeah, there's still some funkiness. So she may have other things going on. Obviously, there are more than one factor involved in
Okay,
most
so
cases.
this is still a little bit lower on this side.
Still funky.
Uh-huh.
The knees are still funky. So
So it's a
something-
little bit like that. Mhm.
Now I'm gonna give my 2 cents, but Sharon has a lot more experience.
Okay, the
When
hips
I
are-
find
yeah.
that the knees still have problems with bending and the shoulders are still messed up, I find that there's a heel lift usually needed. So even the first metatarsal lift
Yeah.
didn't correct it. Like in my case, after a surgery, I had a short by about 3/4 of an inch left leg.
Uh-huh.
So it could be that on top of this, she may need some muscle correction, or she may have a leg or a hemipelvis that's smaller.
But her hips are even right this second.
Oh, hips are even.
The
Okay.
hips are even right this second. So,
Okay.
but maybe we could look at that more
Yeah.
at another time as well. But she's been finding that this has been helping her.
Good.
So at least that's
Yeah.
that's useful.
And
Oh,
the
yeah.
hips are
Okay.
even sitting.
Yeah.
When I sit, they're even.
They're even
The
set.
hips.
The
Okay.
hips are even when you're sitting. Yeah, we
Right,
tested that
we
already.
tested that
Yeah.
already.
Okay.
Okay,
Alright,
so
alright.
for her, we're putting in what kind of lift have we been using?
Number 9.
So we've been using 9 millimeters lift under the big toe, and she's been happy with it. You said
Yes.
Okay, great. So that's good. Okay, so that's what we did for her, and
Good.
hopefully we'll keep looking at it over time. Okay.
Sure.
And see what we notice. Maybe there's other things we'd like to correct.
Does anybody have any
Um,
questions
We're gonna take a look at you.
on this? Anybody have any questions? We're gonna do Stephanie now. Anybody have
Yeah,
any
but
questions?
I have her wear something that people wear a lot, and these are flip-flops. Okay, flip-flops tend to make you worse. So if you have first metatarsal deficit, you usually get a lot worse when you wear flip-flops.
Aha.
So they accentuate your metatarsal deficit.
Yeah.
Yeah. So we can correct them with so take off your flip-flop for a second. So by putting the first metatarsal correction in on your flip-flop, that could improve your flip-flops. So what I'd like people to do is bring their flip-flops in and see if I could correct it if they're going to wear flip-flops.
Okay.
So for Stephanie, let's take a look at her symmetry. Wow, she's getting so symmetrical. Okay, so what happens is when you're wearing the shoe inserts a lot, you get your whole body begins to get symmetrical, and she's treating herself all the time too.
Mm-hmm.
And she used to be asymmetrical. Now she's symmetrical, even barefoot. Okay, so that's good.
Yeah.
That's what happens. That's what, yeah. Now you're symmetrical barefoot now. Yeah. So what it's like your body gets like the set point of even, you know,
Uh-huh.
and then even when you don't have them on, you're still even for a while or who knows how long. You know.
Mhm.
Okay, so let's take a look at her feet. Okay, so she likes to turn this one out here. Okay, and if you turn around, let's look at you, and from the front just for a second. You see that she has a little bit of a bunion here, and her toes coming in there, and she has less of a bunion on this side, right? Uh-huh. Now you started wearing the shoe inserts a while ago, and this one you got rid of the bunion completely. Okay, but this one you tell us what you did. You wore the soulmates on your foot all the time.
Yes, like
Both feet?
Yes, but then there's something up with this one.
Uh-huh.
We still have to
So,
figure out what's going on.
okay, so we're
with
still
it.
working on this one. So
Yes.
this one corrected,
Yeah.
but this one didn't.
Yeah.
Okay, good. Okay, so we're still working on this one.
Yes.
All right, good. So we'll over time we'll see how well this one goes away. Okay. Okay, let's turn with your back towards us again, and we're gonna check other things. Okay, let's have you bend your knees, and come on up, and bend your knees, and come on up. Okay, good. Okay, so we're gonna take a look. And so she's doing that well. She doesn't fall in.
No
Okay,
falling in.
So I'm gonna go ahead and move your foot just a little bit. Move your heel out a little. Okay, good. All right. So I'm just gonna check. Okay, so I'm gonna just feel the subtalar joint between the calcaneus and the talus, and roll your ankle in. And now you can feel a little bit of it, the edge of it there. Now roll it out, and you want it to be flat right there. And when we make that flat and the ankle looks even, we have just a little bit of lift off the ground.
Mm-hmm.
Okay, let's take a look in this side. So let's roll it in. So this is what it probably used to look like, rolled in like that. Now we're going to just make it even. Then we're going to also feel right here where the calcaneus meets the talus, or you can just, or for those of you who don't know that, just look at the ankle and make it even.
Yeah, just
The
make,
two
just make
malleolus
the
is
two,
even. Yeah.
the two ankle knobs,
Yeah.
those malleoli,
Yeah,
just
and
make
then
them level.
take up the slack under the big toe.
Yep.
And then go ahead and bend your knees and come on up and bend your knees. And how's that feel?
It's easier to bend your knees.
It's easier,
Yeah,
Yeah,
it's
so
easier.
it becomes easier to bend your knees. Yeah.
Sharon,
Yeah.
someone wanted to know, I mean, could there be another reason besides first metatarsal deficit for a bunion formation? Well, naturally,
Not much.
not too much.
Because really the bunion is because you're
Mhm.
but there might be, but I just
Yeah.
meant for the most part.
If you had
it's-
like a really bad shortened external rotators of the hip, you could have, a foot
Yeah.
that goes out a lot and putting pressure
there
on.
could be, there could
You
be
know.
other reasons.
Yeah.
Other reasons, if the foot's out, if you
Yeah.
have some reason, then you'll have a reason for going ahead and
Yeah.
rotating in. But it's pressure. Bone grows wherever there's pressure. So if you see
Yes.
bone growth right here,
Yes.
then you know that if the bone is growing there, then you know that the person is actually doing this.
Yes. Exactly.
If you see it, then you realize they're actually doing this, and they're actually putting the pressure right on that bone.
Absolutely.
That's why it's creating itself.
There would be no bone would not be growing there arbitrarily. That
No.
bone is growing there exactly
For a
because
reason.
there's pressure.
Yeah, because for the pressure you're putting on it. Yeah. So,
So-
bone grows where it has stress there.
So on most cases, for sure, first metatarsal deficit is the reason why there's pressure there, because the person has to get around the second toe, which is longer, in order to toe off on the big toe. But there could be, as we corrected, you see this side was fine and this left side wasn't. It could be another reason why that foot is turned out during walking and it's causing, pressure there. Could be another reason. It just, most
Now,
cases, it's the
Because the
metatarsal.
people turn their foot out, it tightens up the gluteus medius.
Oh yeah.
And the gluteus medius causes, if it has trigger points in it, causes pain across the low back. So it's one of the, and it can cause the gluteus minimus, which is underneath it, can cause you to feel sciatica going down the whole leg.
Yeah, exactly. So let's look at the gluteus medius pains right there. I'll show you. So this
Okay.
is the type of pain that immediately, and then if you don't mind, I'll show you. There's a gluteus medius right there.
Yeah.
You see all this butt pain that people have, butt
So the
and
low
back
back,
and SI
low
pain.
back. And then, so that's from turning your foot out.
Yep.
And then here, it's the same muscle. It's the gluteus minimus right underneath it, and it causes pain down the leg all the way down to the ankle.
Yeah.
That's referred pain. That's the same is the sciatica. It would be like sciatica.
And if there are
Okay.
people interested, occasionally I whip out a little applied kinesiology. Hey, Steph, would you stand with your back against this table?
Back
Without-
against it.
Yeah, just so you have something to lean up against. Okay? So, when she's standing with your weight here on your foot, what I have them, so you could brace with one hand here, but just lift this one leg into the air straight side out like this. You see? Actually, do you want to hold this so I can see? Okay? So, this is important to have this kind of strength. Push up into my hand, push. And this extreme weakness, you feel how weak that is? That's I should not be able to move that. It should be nice and solid. Try the other side now. So you're standing with this, and then just push out into my hand. when there should be strength in that point. Now, if I put a wedge underneath and go ahead and try this again, now push out. You see how much stronger that is? Okay. And if I take it out again, watch. Go ahead and give us a good show. I'm just going to, one finger, push hard. Come on, Steph. See? One little finger. Okay, you see a difference? Same thing on the other side.
So another way we could test this to test the strength of the muscle. So
Yes.
anywhere in the body, we could test the deltoid, any muscle in the body, and see if it's stronger.
Well,
Yeah,
actually,
because
this isn't any muscle in the body.
Well, you
This
did
is
you did a
specifically,
specific one.
this one, the glute medius is activated by, push, see? Now all that additional strength, okay?
Oh man, strong.
Yep, so does anybody know why 25% of the bones of your body are in the foot? Is because each one of those joints, so imagine bones of the foot, 25%, there's so many bones in there, and each bone has multiple articulations with every other bone, so there are like a huge number of joints in your foot. Every single one of those joints is sending information up into your brain. That's so you can walk. If you didn't have that joint, if you took out half the joints, you'd have half the amount of information going into your brain, and you'd have half the amount of balance when you're walking. You see, so all those bones, they send information to your brain so you can have balance on your one foot and walk. So you can see that when she has the long second toe, there's that knife-like point causes instability, and the natural contraction of the glute medius on the opposite side doesn't happen because it doesn't sense stability. Okay? So an unstable joint causes muscles to not be confident and strong. They'll retract. So by putting a little stability and giving her that firm tripod, then her other leg was strong and it could do whatever it wanted to do. So think about how that affects sports, affects everyday walking.
Yeah.
Every time she stands on this foot and swings her leg, it's up in the air. And this muscle isn't firing. It's tentative. It's scared. It's worried because there's this, knife that it's on. So that's an amazing thing will happen to you from head to toe when you get a tripod balance on your feet again. Okay?
So there's different ways to measure. We were using these blue wedgies here, but really, let's demonstrate. If we could have you come, Debbie, one more time. The thing is we could also. What if we didn't have those blue wedges? These you can get these from this same company, Posture Control Insoles.
Well, yeah, they'll send you the wedges and everything. When you call them and talk to Bjorn or Milady, they'll send you everything you need.
But even if you're at a pinch, you could check this out. You could use sticky notes.
Post-its.
Okay. And you could measure like that. So this is, you can see, oh, that's 3 millimeters. Then you could measure these and see how many millimeters you have.
Yeah.
And then you could go and check, so this would be, then you could check like this and see if that makes a difference. And it did. So then you could, I guess if we put these in. So this is nice, and you're a Posture Pro when you have these.
Yeah, yeah.
But you can still use sticky notes.
You can write Posture Pro on this.
Yeah,
Yeah,
exactly.
right, Posture Pro on it.
And then if you really wanted to MacGyver it, then you could cut out the exact sticky note
there you
formation
go.
of your first metatarsal. So, by the way, remember, can we show them on the Soulmates where the little pad goes?
Yeah, let's do that.
Yeah.
Let's show you how to do this. So give us that one should be left and one should be right. One would hope. Okay, great. Okay, so we're gonna put these on your feet. Okay, so sit there. Okay, so
I can just walk around with these on.
Yes, you
Yeah,
could.
if you're gonna be
Okay.
barefoot.
Okay, so how would you put them in? See, see, it's thicker here, and it's thinner there. So here's like a little instructions that come with the Soulmates, explaining how to put them on. But I'm just gonna show it to you.
Cool.
Okay, so all right, so we're going to go ahead and take this off, and we put it right on her feet. So I went into Hawaii. It was the most amazing things. This was like surfers who were like 60 years old. I had a series of about 6 or 8 of them or so, and they all had first metatarsal deficit, and they all had really bad dysfunction of their back and their neck and their shoulder. We put this on, and then I showed them how to do their self-care, and they realized they didn't need orthopedic surgery on their spine. They were like, oh my gosh! And so then I just had them get 100 of these because I wanted to be barefoot all the time. And so then they would go barefoot and then wear these. and then they were out of pain, and they couldn't believe it. This is after 8 years of chiropractic, twice a week, and like the chiropractic.
How long do these stay on? I guess
These don't they don't stay on your feet very long. That's why I had them order 100 sets.
You could imagine other ways to affix them better, though. You could, use some skin tape to, go up and around. It might make them last longer. So,
crazy glue.
Yeah, not necessarily crazy glue, but some other kind of first aid tape. Something like that could definitely make them stay on better.
Yeah. So here we got them on. They're good. Or you just order 100 of them.
100 of them every morning.
Okay, let's have you go ahead and stand up. Then we'd like to check her and see if she's still symmetrical. Okay, so it's not as symmetrical as when we had a little higher, but still pretty good. So here, just slightly asymmetrical.
Mm-hmm.
And then here, pretty good.
But some people
Okay, let's go ahead
prefer
and bend your
these.
knees. Uh-huh.
Some people prefer the feeling of the soulmates. How do you feel? Does it feel as freeing or loose as it did when we had the other ones in? What would you say comparison?
I like them attached to my feet.
It's nice to have them attached to your feet.
I like that.
You might like to have that every day.
Yeah.
And you can have those, and then if you were putting on your shoes and you had another 3 milliliters in your shoes, then that's not the world's worst thing.
Okay,
and,
that's what I did with all the Hawaiians.
Yeah.
So I got those they could wear. They wore those barefoot, and then I got 3 millimeters these, and they would wear these in their shoes, and then they would have 6 in some cases
while they were
in their shoes,
Okay.
Yeah.
and then they still had 3 on when they were off.
Yeah.
So, okay, so I just wanted to show these are prokinetics.
And remember, why does that work? Because are you consciously aware that those are on your feet right now?
No, not really. No, well, am I?
When you walk, you feel them. Right?
Actually, I do feel them. It feels good though. It's not intrusive in
No.
any way. No.
Yes, exactly.
It feels supportive.
And yes, it feels supportive. And so that means your body's learning and adjusting and growing. It's getting used to a new posture.
Right.
And that's good. So even if you need 6 and you only have 3, that's still good.
Mm-hmm.
Right,
It's still good.
training them.
Yeah.
So this is what's prokinetics, and this is one of the things that the company sells. Usually what I do is I take out the arches, unless you have high arches. Sometimes I leave them in for you. It just depends. And then here you can see this is 3 millimeters here, the red. But then also you could add. So if you have somebody that you want to start with 3 millimeters and go to 6, then here is another one that you could have, and then you just glue that right on.
So what this is it's the same company, exact same product, only this is a slightly more adjustable version so that you can graduate from 3 millimeters up to 6 and even to 9.
Yeah, and it comes with a little bit of glue, and then you glue that in. So then you could take it off later if you didn't need it, suppose. Or if this would be like a way of gradually going, and you don't know if you needed 6. We'll just see. So this is a little gift for you. We're going to give this to you to take home.
Thank you.
And
Well, you've been a fabulous guest.
and so
And everyone in the studio audience, yes.
Yeah, that's right.
This
You
is
have
the
to have
Oprah
you
Okay.
have to come in person.
We need someone holding a sign that says applause.
Have her stand on those and test
yeah,
her?
we'll do it. We'll do it.
Yeah.
Okay. So let's go ahead. Let's put the 3 millimeters in.
Why don't you take them out for a test drive?
That's right. Oh, I love the surface.
Yeah, these are quite
They're like
comfortable.
suede or
Yeah,
something?
like
Are they
suede.
Yeah, like suede. I don't know if it's
Yep,
real
they're really
suede,
nice.
but
Real suede.
yeah. Wow.
Okay, so here.
Okay.
Oh, now she's more. Now she's even. Oh, now
Okay.
she's better. I can
Okay,
see.
great.
So now she's got the 300 feet.
Yeah.
I
And
feel
the
like
3
I'm
more.
standing really upright.
Now
Yeah.
she's more upright.
You feel
She's-
upright and good, right?
Yep. Mm-hmm.
Great.
Mhm.
Yes.
Yep,
Oh yeah, you can see there's a comfortable, straight
Yeah, looks
posture.
good.
Wow.
So
Very
this would be-
relaxed feeling.
So this would be a good direction for you to either go
Yeah,
with.
oh yeah, take him for a ride. Look at that smooth.
Wow.
She's ready for the what's that ski jump? That,
It's so much easier to bend my knees.
so much easier to bend your knees,
so-
like almost as if someone lubricated all the joints
Yeah.
in
So
your knees, right?
Justin, somebody in the building next door, the Ritz Apartments,
Yeah.
they just walked up Mount Olympus in Greece and told everybody else in the building there that
About the Greek toe.
about
Greek toe.
how creak toe and how we corrected her feet, but she was told 2 Christmases ago that she needed a total knee replacement. And I looked at it, I had an x-ray, there was nothing wrong with her knee.
Yeah.
So I decided to correct her toe and correct her knee, and now she walked up Mount Olympus.
I'm telling you. The amount of muscle tension that causing your knees to become so tight and worn out from normal activities because of that. Yeah. It's just like lubricated. It's added 30 years to her knees. You know. It's just like it's so useful. Maybe more.
Okay, so we're going to also take a look at teaching you. If you just go ahead and sit here with us for a second, Debbie,
Yeah,
over here.
we have
So,
one more thing before we close the class tonight, folks. Is that, and then I was going to promise to do my thing. I have a problem with all dependency-based medicine. I'm against it. So I don't want these orthotics to become dependency-based. Dependency-based, in my opinion, means you don't learn anything. You don't awaken to a greater sense of your own intelligence by using it. So in this case you do, but even more so, I want them to not only wear the orthotics, but I want them to grab a hold of their feet and become best friends with their feet. I want them to know their feet inside and out, and Sharon feels the same way. They should play with their feet now that they've realized how important they are. So not only give them the soulmates.
So here that cause bunions, okay? So here the adductor hallucis, the abductor hallucis, the flexor hallucis brevis, the flexor hallucis longus, the interossei of the foot, and the great toe joint.
This is not a handout for your patients. This is for you to know.
Oh, yeah.
The handout for your patients is this. Protocol number 36 and 37. 37 actually starts the next page. Yeah. And there you see it, treating all the interossei of the feet. And then you're going to draw on it with your fancy highlighter. Teach them to treat all these parts of your feet right there, right?
Right.
But for your professionals, these are the ones that you know cause bunions,
Claw toes,
and
hammer toes, yes. So these are the things that she has hammer toes too, so we want to be treating the extensors, the lumbricals, the interossei of the foot, and the toe joints. So this is all the things. So I was going to show her how she might treat some of these herself.
Yeah. Great.
So we're at the end of our show.
We're at the end of our show?
Yeah, but we could keep.
Bravo.
Well, can you quickly
Thank you all
show?
for coming.
Can you quickly show how someone might just take a pencil eraser or something and work the interossei?
Okay, so let's take a look how we might do it.
My personal opinion
Can I
is
have the footstool?
that the most important thing that gets messed up neurologically is the interossei. These toe joints tell your body what to do in space. They tell your body how to move and how to balance. These interossei joints right in between here. There is imagine there's 100 supercomputers in here, all sending information up into the brain, the cerebellum, the cortex, the motor cortex, telling the motor ventral side of your motor horn in your spine to control every muscle that goes from here on down. It's like these are the little control centers for all those muscles. Your entire brain, your cerebellum, your nervous system, your body, it depends on these little joints to tell it where you are in space, where you are during your gait cycle, and how to function. So Sharon and I treat the interossei all the time.
Okay, so we're going to go in between the toes. And we have the ball pressing up from down below, okay, Debbie? And this pushes from down, so you're getting pressure between the toes. And a lot of times I'd like you to wear yoga toes between your at the same time.
Okay.
And then that's stretching. Stretch, yes, toe spreaders, but significant toe spreaders, so that stretches the interossei at the same time while you're pressing in on them. So let's go ahead and you try that. Go ahead between the second and third here.
And if it's tender, you know that joint has not been sending good information. A tender joint has been saying, don't do it, don't do it. That's what a tender joint tells your brain. Don't do it. A non-tender joint says, hey, go ahead and do it. And so that's why when we put the lifts underneath her toe, the muscles controlling her knees said, hey, go ahead and do it. And she felt relaxed and easeful in her knees. And then we took the metatarsal lift out, the joint said, don't do it. And as she tried to bend her knees, they got tight and stiff. So you want your joints to say, go ahead and do it. And they're all
And they're all tender.
Yeah, they're all tender,
they're all
right?
really
Just
tender.
amazing, right?
So
people
go ahead and give
don't
me your other
realize
foot.
that people don't even realize that they could be not tender. That's how long they've been used to it.
Okay, so on this side, we're going to go ahead and treat in between the toes here. And we'll see with a little more dysfunction.
Do that again. Oh yeah.
So go towards
Someone
one
asked
toe.
if that hurts.
So here, you can see, you know it's dysfunctional when you see this myofascial pitting. That's not, she has no edema.
No,
This is the muscle stopped working.
the muscle.
So
has
what if we
become
got that
pitted,
muscle
yeah.
to work again? Okay?
Yeah.
So what if we gave a platform for this toe? And what if we change these muscles? Maybe we'll see in a future, you'll come back on a future show and you'll show us how it's
I'm not
improved.
coming back. No. Yes, I am. I'm kidding.
This, you know, a pencil eraser works in a pinch if you're at your office too.
Yeah.
Oh, that's a good idea.
Yeah, pencil eraser works. It's a good shape for it. So then we go in between each toe. Okay. Then we also want to work on the abductor. So that would be coming here, starting right here, and then we work at it. We shorten it, and then we lengthen it. Okay, we won't push it too far. We'll just shorten it. Yeah, and then we'll lengthen it.
I think it's more I'm afraid. It's not that it's.
Oh, shorten it and lengthen it. And we're going to shorten it so it attaches all the way over here. So we're going to come all the way and shorten it and lengthen it, get right on it like that.
Yeah.
And
That
we're
feels good.
challenging it a little bit. You
And
know?
you guys won't believe it, but I'm telling
Mhm.
you, when you first touch it, you'll think, "This is so painful. This can't be
You
good
can't,
for
you
me."
can't, you can't.
There's
ever do
no way
this,
you can do
yeah.
it. And then there
Okay,
will
then.
come a point, I promise you,
Okay.
even in a minute, I will
Let's also do-
sometimes do this too. Here's another way you can use. Yeah, you can use a pincer technique. Actually, no, you won't do that. So I'm gonna lift your foot up. You can use a pincer technique. Right here, you grab underneath there and the top, and like this,
yeah.
squeezing with a little bit of rotation in like this. You see that? This it will hurt like the dickens, and then it will go away. It'll magically melt after a minute or so. And then that joint will give you so much more happy feedback and allow you to do so much more with your life. This one you can tell right in there. Yep, she's getting a good one right there. So
Is that, now I'm feeling it that it hurts, but it feels good.
it feels good. It's
like,
almost
wow.
feels like it's activating
good,
your
yeah.
nervous system.
Yeah,
Don't you
yeah,
feel
yeah.
almost like your nervous system is waking up?
Yes.
So other muscles that you'll want to treat are these ones underneath here.
Okay.
Yeah.
So this is the adductor of the great toe. So the one that makes the toe come in. So it's attaching onto every one of these toes in here. So we can work on it like this with our little tool, like that.
That's exactly where my thumb was underneath. I
Okay.
had my thumb there, or
Okay.
sorry, my index finger underneath and my thumb on the top.
Okay.
That's
So
exactly-
so a really good way to treat it is from the top and the bottom.
Yes,
Right.
exactly.
So we can go like this and
Yep.
pinch it between. So
Yep.
this is a good way. You could also do it with the tool from the top or from the bottom.
Okay.
You know.
Yep.
So this would be but we want to particularly get the toe to come out,
Uh-huh.
and we want to get all these leg muscles to actually do their jobs. So
This calf
Mhm,
is almost an inch bigger than the other one.
Yeah, yeah,
Because
so-
of this.
because we're working so hard,
Yeah.
so you can
Yeah.
feel these are real tight. So
Yeah.
so we'll know this is better when this isn't so tight anymore.
Right, yeah.
When all these muscles are working, we get a place to put this, and then you're retreating this. Now I told you it took me 6 months
6 months.
every day,
But
and I
that's
totally
bad
got
bunions.
rid of worse bunions than your other foot.
Yeah.
Okay, this is the surgery is a complication. I couldn't say precisely the exact
yeah.
outcome of this one.
Because I have been trying to, because the way this has been set, I've been trying to, that's why I taped this toe in here like this.
I think we
which
might be able to
gives-
correct it. We'll just see.
Okay,
We'll
all
see.
right.
We'll see.
Because
Yeah.
it's so funky out there. It's not
Yeah.
touching anything. It's
But
just
but
out
but if
there.
we if we change these muscles,
Okay.
we put a lift under the other one,
Oh.
and we work with all this. Let's see if we can't see an improvement in it over
All right,
time.
I'm
Yeah.
game. I'm
Yeah,
absolutely
yeah,
game.
yeah.
All right, guys. So now you know it. You have the reason we took a whole class all on this subject is just because of how important it is. This is going to totally change someone's life, very very quickly. And you know, I had Mike Tyson as a patient. He wasn't the boxer, but he was nevertheless a really big guy named Mike Tyson who had done everything for his low back pain, and including spending 6 weeks with us. For some reason, we just were negligent in giving him this treatment because he already had orthotics. He wasn't interested in it or something. And at the end of it, he said, well, almost everything else in my life is great. My diet has changed. I've lost weight. I feel great. My headaches are gone. But my low back pain still hurts. And we took out his rigid orthotics and put one of these toe lifts in there. And he felt his back pain go away as he was standing on them. And that was it. Sold him on it. And then he never had to come in for another appointment. So, okay. All right, guys. We need to close off. Let everybody go home. Enjoy the rest of their Tuesday night. How about some foot range of motion?
Okay. Yes, so here we go. Like this.
Who want you to remain free. We will assess and use heat. Then compress and repeat.
Thank you guys. So good. We love this. Thank you. Everybody is so happy. Good, good.
We'll teach you how to do self-care.
Well, we love you guys.
Will keep you at your peak. So see you back again next week.
All right. You guys make all this worth it. Thank you. We love doing this and we love having you guys. You're awesome. Bye.